the webinar. Okay.
Good morning, everyone. Welcome to 1Q 2025 Siloam Earnings Call webinar. I'm Vivian, the Investor Relations of Siloam. In today's webinar, we have Pak Daniel Puah, we have Pak David Utama, Pak Sumanta Ray, and also Bu Karen Riyadi will be joining us soon. Without further ado, let's start the webinar, Pak.
Okay, thank you. Thanks, Vivian. Welcome, everyone. Thank you once again for your continuous support. Today, I would commence with a short summary in regard to the results for 1Q 2025, sorry. And then Carol and Sumanta will then go on to tell you more about the business operations. Next, please. So in regard to the financials for 1Q 25, as you all probably well know, 1Q 25 has been a relatively flat quarters for the healthcare industry as a whole. I think there's a few factors affecting Q1's performances compared to Q1 of 2024. Two factors. Primarily, there was a seasonality in last year in regard to there was a spike in the dengue disease pattern for which that was not repeated in 2025. And also the number of effective productive working days is less in the first quarter of 2025 compared to the first quarter of 2024. But as you all know, the Baran is obviously moved forward. And then we also have the issue of, the Chinese New Year, falling in between the long weekend that had an impact on business performances. And also the government's work from anywhere policies also affected the revenue during the Puasa period as well. So as a whole, as you can see, revenue is flat at 2.35 trillion compared to last year. The rise in the cost is generally below budget. But obviously, as a result of the flatter revenue, you see that the EBITDA in this case is down slightly at 500%, down to 670 billion. EBITDA margin is maintained at 28.5%. You will see that despite the reduction in the EBITDA, operating cash flow continued to improve by 2.1% to 400 billion. And this is again as a continuous measures for us to improve the working capital. All in all, if you look at it in terms of the trend, we are still showing a revenue CAGR of 7.1%, from 23 onwards, Q1Q, and 12% CAGR on the underlying EBITDA. Now, again, just a reminder, the underlying EBITDA, the adjustments primarily affect to 1Q 2024, whereby there was a adjustment due to the properties that will no longer be proceeding as hospitals. So we took out the impact of that from the 2024 results so that you have a more comparable result of the EBITDA last year versus this year. Okay, next please. So in regard to the mix of corporate and insurance segment, you will see that BPJS segment is showing a decline, down by about 3.1%. This is due to generally tighter referral from the BPJS sectors. Picking up from that you will notice that the private group, the OPE grew by 2.5%, and the corporate insurance relatively flat by the growth of 0.1%. Sumanta will touch on this later, but we are glad to report that a lot of the negotiations with the corporate insurance segment has largely settled. Remember previous quarters when we presented this, we did mention that there's pressure from the corporate insurance sectors. We're glad to report that it's largely settled. So we should see that going into a stable phase going forward. As a result of that, you see that the private payer segment rose from 32.4% last year up to 33.1% this year. Next video. I think despite the reduction in throughput for Q1, for mainly the seasonality in disease and also effective working days, we are happy to report the fact that our average revenue per occupied base continue to improve and grow. So you see that this is a 10% year-on-year improvement on ARPOB and 6% improvement on average revenue per patient days. This is consistent with the strategy from Siloam to continue to improve on equity, increasing on complexities. So we are happy to report that this is definitely shows that we are trending in the right directions. And I think throughput would go up and go down each quarter depending seasonality. What's important for us is that we continue to execute on our strategy because the improvement in the revenue intensity, we believe that will give us a steady platform in regard to our competitive advantage and the differentiating factor for Siloam going forward. So for us, that is definitely a very important matrix to be monitoring and ensuring that we are increasing our revenue complexity and accuracy. Next video. The throughput, I guess, this ties in with the story that I've been telling, but due to the lower working days and the disease seasonality, you see that throughput across the board, outpatient, inpatient, is generally down, with outpatient down 2.7% and inpatient down 7.1%. Year-to-date basis, patient admission is obviously down 9.2%. Now, this obviously is what's contributing to a relatively flat revenue. As I said, the ARPOB has picked up, so despite the lower throughput, revenue has stayed flat due to the improvement in ARPOB. Coming back, I just want to repeat, throughput will see fluctuations quarter to quarter, but ARPOB is a competitive advantage that we want to build upon quarter to quarter. Next video. The cost structure and margin is, I would say, relatively stable. If you look at the movement for 4Q to 2Q, drugs and clinical supplies from 28.7%, stays relatively flat at 28.9%. Operating expenses from 4Q to 1Q, that fell from 33.2% down to 30.6%. Remember, last quarter I did mention the increase in operating expenses due to a lot of transformation expenses that we are implementing in order to execute the abstract transformations. Pasumanta, which has been a key lead in executing the abstract transformations, would tell you more about what we have been doing. But I think, as a CFO, I want to say on the ground, we are definitely seeing a lot of traction and advantages that the abstract strategy is bringing to the business. The results may come a bit later because obviously in between this transition stage, there are some friction costs related to the transitions that we have to bear. But based on what we are seeing on the ground in terms of the operational efficiency and improvement, we are actually very satisfied with the progress that we are making on the ground. And we do believe that over time, you will see this result reflected in the financial as a result of the operational improvement with the abstract implementation. But in the short term, obviously, there will be some friction costs coming into our operating expenses. EBITDA relatively stable at 28.5%. I mean, we're still aiming for a 30% margin. I mean, once some of this transitional and friction cost is stabilized. In regard to the net profit margin, you will notice that that fell slightly from 11.7% down to 10.9%. Now, a large reason for the drop in the net profit margin is due to a rental increase. And I think I mentioned this previously. Our rental, the first rate is based on a percentage of revenue. And the percentage of revenue that is based on previous year's revenue. Yeah. So what it means is that if you recall, Q1 and Q2 of last year saw significant growth, obviously due to this seasonality. So first half of 2024 saw like a 14-15% growth in revenue. So a lot of that is then translating into the rental increase for 2025. But because the actual revenue increase is relatively flat, but the rental increase is baseline on last year's revenue improvement, you will see that having an impact on your net profit margin. Now, again, recall the rental due to the PSK 73 calculations doesn't get reflected in EBITDA, but it gets reflected in your interest and depreciation costs, right? Which is why you're saying that the EBITDA margin is still relatively unstable, but the impact of rental increase, then a lot of that gets reflected in your net profit margin. which is why this is also why it's key initiative from the law. As you've already seen announced for us to initiate the buyback of 14 hospitals from first week. Okay, next week. Operating capital is stable, but working capital days is still around 4 days. And we are, as a result, as you can see, operating cash flow is seeing a continuous year-on-year improvement. And 400 B, I mean, for 1Q24 is probably one of the strongest cash flow we've seen in terms of 1Q, despite the fact that result is still relatively flat. So for us, we do believe that that's important matrix for us to monitor. So with that, that's all my presentations for financials. I'll hand the time back to Pastor Manta to tell you a little bit more about our archetype transformations.
Thank you, Dana. Good morning, everyone. For those of you who have been following Siloam for quite some time, you will know one of the key linchpin of our strategy going forward under the Next Gen Siloam project is about the archetypes, where we are carving out 4 independent networks within our Siloam network. Next slide, please. So if you look at this, there are like kind of 4 archetypes: premium specialist, which has 6 hospitals, premium generalist 9 hospitals, value seeker 13, and community generalist 13. To the best of my knowledge, I don't know any hospital network in the world which has managed to segment its network into 4 networks and do it as per customer segmentation. And then if you look at the numbers at the bottom of the screen, you'll be able to see that and appreciate what I'm talking about. The 2 premium archetypes on the revenue side contribute to 70% of the revenue, while the non-premium archetypes contribute to around 60% of IPD volume. So it's a volume and revenue match, and that's how we have kind of broken it up into 4 archetypes. Next slide, please. So if we look at what are the key focus areas for each archetype, I will not read out the individual points, but in terms of the premium archetypes, you will see the entire focus is on building clinical acuity. It is about getting doctors, putting more high-end clinical focus, because what we are trying to do for our premium archetypes is to kind of benchmark it to the best of Southeast Asia. And that is the area where we want to reach. So the premium archetypes are focused on building clinical acuity, whereas the value seeker and community generalist are focused more on operational excellence and management of PPJs. How do we drive the revenue acuity on the archetypes? There are basically 4 things which we are largely doing, and I will talk about a few of them in the subsequent slides. First is we are stratifying everything by archetype, like I mentioned earlier. So there is brand stratification and there is a price and offering stratification. The other thing is the focus on premium, where we are really building a referral network and focusing on the Congo Euro Nephro, which is the mainstay of surgical capabilities of Siloam. A lot of marketing on that on the commercial side. The third is for the community generalist and value seeker, we are looking at focusing on coordinations of benefit, COB, which I'll highlight later on. And the fourth is to look at conversions. Next slide, please. So as far as the brand stratification goes, till now, we have had one Siloam brand and one Siloam experience, by and large, spread across all our 41 hospitals. Now that we are moving to an archetype model, for each archetype, we are segregating from a communication perspective, so putting up a clear brand identity and consistent communication, as well as also on the experience side, very focused on tailored offerings, focusing on service excellence, and aligning the infrastructure in terms of the archetype. So the brand stratification is happening both from a communication perspective and a patient experience perspective. And this is a journey we have already commenced and walked quite a distance. We will hope to see more as we go along. Next slide, please. The other thing is, once we have stratified the brand, we are also stratifying price and offering so that the price value equation of each archetype is aligned. And accordingly, we are doing a massive reorganization of our entire pricing structure to align with each archetype. And that is one part. And the second part is also try to bring predictability to our entire pricing process, both for our insurance partners, as well as our patients. So we are rolling out something called an ETBS, or estimated total bill size. We're using extensive use of AI is happening on that to give a predictive bill size at the onset. So these are the two things which we are right now combining to bring further value extraction into our archetypes. Next slide, please. The third thing, especially for the non-premium archetypes, especially the community generalist archetype, which has a large BPJS mix, we are actively looking at managing the case mix by working on the coordination of benefits. So coordination of benefits, for those of you who may not know, is essentially where two multiple payers come in to pay for one patient. So anybody who has a BPJS membership can either go for a top-up, which I've highlighted in point 1, or a corporate we could tie up where the base part is paid by BPJS and the differential part is paid by corporate. That's the point number 2. And the third, the same thing for insurance. So with this, we are trying to ensure that there is a certain amount of case mix management, so that at one hand, of course, for community generalists, we are really going for BPJS, but at the same time, we are using COB transference into BPJS into non-BPJS revenue, because once you go into COB, you get the total revenue, so it kind of moves from BPJS to non-BPJS. Next slide, please. So, and I come, this is the last slide which I'll talk about, which is the fourth revenue parameter is to look at conversion, to look at a full patient lifecycle management project, where we are looking at all the funnels that kind of build the revenue and the throughput, either in 3 stages. Before they come to our OPD, the OPD to IPD conversion, and the post-discharge conversions. Because in any hospital system, there are a lot of opportunities for leakage, and these are the areas which we are trying to fix so that we are able to kind of maximize the conversion and drive further revenue. There's a small example we have put on one side, which one of the areas where we have seen a decent amount of success is the conversion to surgery and thereby higher ARPOB. And I'm just sharing an example of Siloam, Palembang, where in our pre-operative clinics, we have managed to push up the conversions to surgical cases by managing dropouts. A lot of people who drop out, there's a process behind that to manage that, and thereby have been able to push up ARPOB as we go forward. So these are a few of the initiatives to drive revenue equity in the revamped archetype structure. Archetype by archetype, we are using that to build blocks of revenue into the overall Siloam system. Next slide, please. Thank you. And now I would hand over to Bukarel to take forward the business update section, please.
Hi, good morning, everybody. Thank you for joining us again at our Q1 earnings call. Thank you, Samantha, for the elaboration. You've been hearing about the planning and the preparation for the archetype, and currently we're in the thick of the execution. I hope that through Samantha's presentation, you can see the rigor of the execution that we are doing, and also I hope that you can start seeing the identity of each archetype taking shape, each by a different set of levers. I'm going to share about some updates and business highlights in Q1. The first one I'd like to share is we've had a strong launch of the robotic surgery program at Siloam with the first Da Vinci Xi in Indonesia. which we've shared with you last month. But now we have done 2 very successful procedures in the first 7 days, and the third scheduled within the next week. Given our patient base and talent, clinical talent, we look forward to seeing this program take center stage over the coming months, elevating clinical capabilities and patient outcomes. So this is very good news that I want to share with you. The second one is, again, another very strong launch of another center, which is our Sports Medicine and Performance Center, located in Siloam, which is our orthopedic hospital, bringing science and technology to rehabilitation and optimizing performance. We've had the privilege of working with a number of national athletes, post-trauma, post-surgery, and then outcomes are really impressive. The idea behind this center is not only to complete the spectrum of orthopedic services, but also focus on wellness, on active living, and on longevity, which is a good thing for us to focus on as a hospital and encourage people to have a more active lifestyle. The third one is the launch of our Stone Center, urinary Stone Center in Siloam Astri, which is our uronephrology center as a one-stop center for stones with all the technologies of stone extraction, PCNL, EWS, rares, etc. These are all tools for extracting stones. And given that Indonesia is on the stone belt, and given the prevalence of kidney stones in Indonesia, this is a much needed center. So you can see each one of these happening in our premium hospitals, 1 premium generalist and 2 premium specialists. And this is an example of how we're building out capability in our PS and PG archetypes. The third one is around stroke. 15 of our hospitals have been awarded as stroke hospitals by the World Stroke Organization, which requires hospitals to have certain infrastructure, capabilities, processes in place. This includes having 3 different specialists available 24/7, CT/MR, door to CT, turnaround times, etc. And that was a process over the last year of getting awarded. The teams have put in a lot of work into this. Really has been a team effort, and that makes Siloam the largest stroke-ready hospital network in Indonesia. The aspiration is to grow this number to 24 hospitals in the coming months, and it does improve stroke outcomes and gives patients, give confidence to patients, and again reinforces that brand equity and brand strength and what we're known for. Moving on to awards, besides the World Stroke Organization awards that I just alluded to, we've also, this is the oncology summit. Are we missing a slide? Let's do this one first. We have also been awarded a number of awards from Healthcare Asia, includes Clinical Initiative of the Year for Stroke-Ready Hospitals. We also were awarded, MRCC was awarded Specialized Hospital of the Year, ASRI Tertiary Hospital of the Year, BIMC Nusa Dua Medical Tourism Hospital of the Year, where we do a lot of plastic surgery for foreign patients. The last month, we had 85 plastic surgery procedures for 85 patients, mostly from Australia, but now also coming from other countries as well. So, you know, the health ministry and the tourism ministry has really been focused on medical tourism and seeing what can we do, how can we make it happen. And we see that BIMC Nusa Dua is a project that we've been working on in the last 10 years, and it really is taking shape, and people are starting to recognize that. So that's something that's very exciting that's happening. The last is the Oncology Summit that we had recently, with a very well-attended Oncology Summit last with over 700 participants from around Indonesia and speakers from around the world, including MD Anderson Cancer Center, who, as you know, is the #1 cancer center in the world today. We had a combination of plenary sessions, workshops, discussions, and so there are a lot of praises coming from the Oncology Summit that we just had. So you will see Siloam consistently focused on strengthening clinical capabilities that are relevant to the needs of Indonesia. And this is not something new. It's not something that we've started in 2025. We've been talking about this for the past 5 years. And so this is a continuation of this journey, and we do not stop. And by doing this, we're also raising the bar for the country, improving accessibility for patients, focusing on quality. And this is also a sustainable way of raising revenue intensity over time. So hopefully you're as excited as we are on these latest developments. I will pass it on to David to share some ESG updates. Thank you.
Thank you, Caroline. On ESG, next page, please. I think this is something that we are equally excited and very committed to. Siloam has demonstrated a very strong commitment to environmental, social, and governance principles. We are integrating them into our business operations and strategic initiatives. When on what you can see on the page here, we are really committing to the best-in-class sustainability disclosure by aligning both from a regulatory requirement and global reporting standards. On the left, you see the standards that we adopt nationally with POJK, which is the Peraturan Otoritas Jasa Keuangan. Basically, this is making sure on the POJK is enhancing the transparency and accountability. And at the same time, we follow the Surat Edaran OJK, which is assuring consistency and quality being delivered to stakeholders. On the international side, we do follow the global reporting initiative called GRI. And the significance of GRI is actually following the in accordance option, where before we were doing the in reference. So but the difference with in accordance is we are fully complying to the GRI core requirements. And also on the SASB, which is Sustainability Accounting Standards Board, we are the first hospital in Indonesia to adopt SASB standards for healthcare delivery. Basically, this is to ensure ESG is fully integrated into our risk management and value creation process. And also to ensure of the standard, we also are the first network hospital group in Indonesia to have our sustainability report assured under the AA 1000 AS. This is to do a few things, to evaluate and ensure credibility, accurate, transparency, and stakeholder focus are implemented in what we do. So if you look into the journey, what we have done from 2019, we started this whole sustainability report until today, and then we're aligning with POJK from the beginning, and we're adopting the SEOJK from 2021, and we tighten it even further 2024 using the full compliance in accordance to GRI and following the SASB. So with that, we are truly becoming a hospital that is committing and fully adopting ESG into whatever we do every day. Next page, please. So this will give you an understanding of the type of framework we adopt into our ESG practice on running the hospital. We are number one, we care for our patients is one of the ESG framework. With this caring for patient, we have a few initiatives. Obviously, digital transformation is a big piece of what we do, making sure that any patient that is doing transaction with us or being adopted into our system can have access through apps that will help them with every record that they have. Also, the AI integration is a big piece that we do. Caroline talked about it many times. This is the next thing of how we operate our operation. And also, if you look into caring for an environment, this is a big piece that we are so committed in running our hospital. We are, besides the ISO certification, on the waste bank, for example, we are one of the very few hospital networks that are implementing non-infectious recycling initiatives in our 32 out of 41 hospitals. Decarbonization plan, net zero, we are targeting by 2060. You can see a lot of reduction that we are driving through this initiative. But the next also exciting initiative that we do on the framework of ESG is actually caring for the community. The one program that we have been very proud of is Selangkah, which is Semangat Lawan Kanker, is basically doing early screening for breast cancer. And we have done this program for 2 years. End of 2024, we have reached almost 28,000 women in across the country. We are doing it in all major cities in Indonesia, and we are collaborating with many institutions. Selangkah today is no longer a brand name that is Siloam pushing. We are collaborating with everybody, so we are adopting Selangkah for a national project. Papua Clinic is something that we are very proud of. We have 7 clinics serving indigenous people in the mountain area, the most remote places in Papua that is very difficult to access. On some awards, we have ACES and GRID, but move about caring for our people, which is another fundamental that we believe is going to be critical for our success. We are adopting the ISO standard 45001, and we also create the medical personnel scholarship. Basically, we have given about 200 plus nurses scholarship, 10 specialists, doctors, and a few others. So we are so committed becoming, because people is also a pillar in our next gen Siloam, to be the critical success factor of how we do our business. On training center, we have trained 9,000 plus participants throughout the program. The Mokhtar Riyadi Innovation National Championship is being implemented for us for innovative ideas. And we have also deployed quality awards to get the most creative thoughts from our team of how can we take this to the next level. So if you can look into this ESG, our commitment is obviously a net zero by 2060. And we have a medium target as what we specify, which is basically in line or above the standard that everybody is driving toward ESG. Hopefully that gives you a understanding of how serious we are in Siloam of driving ESG and sustainability into our daily operation and execution. Back to Vivian.
Thank you, Pak. Thank you, Pak Daniel, Pak David, Pak Sumanta, and Bu Caroline. Now we will open the floor for Q&A. Just a kindly reminder for participants who would like to ask questions, please kindly use the chat box. Please kindly use the Q&A function in your screen. Thank you.
Carol, you're on mute.
Hi. Oh, sorry, David, you need to. Okay, so I think I will take the first question around government healthcare policy. So there is one piece of policy that is not new, but the government is pushing for implementation, which is the KRIS. So with the KRIS, a few things, right? There is a transition of the way hospitals are evaluated, classified, and also a minimum standard for rooms. So the first one is hospitals will no longer be categorized based on the size of the hospital, but they will start to be categorized based on the competency that is in the hospital. And I think this is a good thing because it avoids patients being referred multiple times up the referral chain for BPJS, which is an inconvenience for the patients, but it's also a leakage for BPJS as well. Now, the second one is a minimum requirement for classes. And also number 3 is then BPJS will not have class 1, 2, and 3. They will just have 2 classes, which is the 4 better and the 6 better. And the 4th change will be that hospitals will be on a single tariff. So we'll not have tariff for ABC, class 1, 2, 3. It'll just be a single tariff. So on number 1, 2 changes, number 1, 2, and 3, we already know. What we don't know is what the tariff is going to be, which could be a little bit of a curveball. And so that announcement comes in July 1st, and we're waiting for that. In the meantime, we're ensuring that we have proper plans to get all our hospitals to comply with the regulatory changes. So that's one specific change in regulation that I can share with all of you today. Thanks.
Okay, I'll take the second questions because I think it's mainly accounting related. The ROU related item increase, I think as I alluded to, two reasons. And primarily is due to the rental price increase, because that is reflected in our ROU classifications. Rental, coming back to first rate, is based on previous year's revenue. We did have a strong 2024, relatively speaking, and therefore you're seeing that increase. There's also some accounting adjustment related to again, I mentioned earlier, the 3 properties that we bought back in Q4 that basically adjusted items. Ingrid, I'm happy to take that with you separately because it is quite technical. The strong OP results despite the holiday, while as I was mentioned before, our POP has improved, 10%. And at the same time, the shift in payer mix with higher OPE and corporate insurance and lower BPJS that affected the OP results as well. How do we manage using the same Siloam brand? Maybe Samantha, I'll let you take that questions in terms of the branding.
Yeah, sure. So like I mentioned in one of my slides on the brand stratification, we are working out kind of a separate brand identity strategy for each of the archetypes. So while there will be the overall Siloam overarching brand, each archetype will, within premium, non-premium, all the 4 archetypes will have separate brand identities. Those are things we are working on, and we will hope to share an update in one of the next calls. Thanks, Tom.
There's a question by Paul Chu, and that is around pricing. I think this is an interesting one, given that pricing is a lever, and we're also trying to do a little bit of a reset on our pricing so that we have better structure, better transparency, consistency within the archetypes and across archetypes as well. Samantha, maybe you can elaborate a little bit about the pricing project that we're doing. This question comes from Paul Chu. It is the last one in the chat box.
Sure. Thanks, sir. So in terms of the pricing project, and this is one of the slides which I had shared, we are doing a price alignment to the archetypes. So 2 things we are doing. One is, while we are doing that, we are doing a major price item standardization. As the Siloam grew organically, we do have multiple, pricing for individual hospitals. We're bringing down to one set of standardized pricing and nomenclature. That's part 1. And second part is we are also looking at a benchmarking exercise as well as looking to align a price, the pricing architecture aligned to each archetype. So there will be price differentials between premium and value seeker because linked to the value delivery, whether it's the experience, whether it's the clinical acuity, that will drive the price. So it is a function of the archetype and the location and the market. But yes, there will be a differentiated price delivery linked to value. I think the second part of the question is on refinancing. So Daniel, you want to take that from Paul?
Looking at, just going through the questions, the reason for the salary cost increase in 1Q25, well, that is within budget. I mean, each year, obviously, we do have to make salary adjustment due to the movement in minimum wage and so forth. But definitely, I think that is within our budgeted amount. Quarterly revenue has been about 3 trillion since 3Q23, and the revenue target going forward I think we have given that guidance previously and we haven't changed. Basically, 2025, we are expecting low to mid double-digit growth in regard to revenue. But obviously, Q1, as I mentioned, has been affected by seasonality. But in regard to the full year guidance, we are still looking at the same numbers. So we haven't really changed that internally from our budgeting purposes. We haven't changed our targets for this year either. So Ari's been asking on the top line, elaborate. Can you share color on revenue growth needed this year to achieve 30% EBITDA margin target? I mean, Ari, I think coming back, that's we basically are sticking with our goal of growing the revenue double digit, mid to low double digit. So, and as I mentioned before, Q1, there's still a bit of a friction cost as well. And Q1, yes, the EBITDA is at 28.5%, but then Q1 is also typically a much softer quarters. We do expect subsequent quarters because of the shift in the effective working days. Q2 should see a bit of adjustment compared to last year's as well. And we still believe that the 30% EBITDA margin target could still be achieved this year. Also, I think with the shifting in payer mix that you're seeing right now, I mean, with the BPJS shifting down, that would obviously contribute positively to the EBITDA margin by itself as well. Ari has a question on the Ashtan model and the sense of the magnitude of revenue intensity uplift that we can see from these segmentations. I think, Sumanta, I'll let you take that questions in regard to the Ashtan model and the revenue intensity uplift that we can expect from the Ashtan model.
Yeah, sure. So a couple of things on the archetype model, obviously, like we mentioned in the earlier point about pricing. So there will be a certain amount of price differentiation. The other thing is also case mix management. Obviously, the BPJS, non-BPJS kind of case mix management also will move the revenue intensity higher. I think whatever we have planned for this year is already kind of baked into the revenue delivery that we are seeing, and we will see more intense revenue delivery as this thing kicks over the next few quarters as we go now.
So I'm going to add a little bit to that because I think there are a lot of questions around the archetype, around revenue, around EBITDA growth. So number one, revenue intensity increase is not going to happen overnight. These are things that we're building sustainably so that we know that there's longevity to the things that we do, such as the clinical programs that we're doing, the pricing project that we're doing. But in a nutshell, a few things, right? Mainly is we need to grow our top line. Q1 has been a softer quarter. There have been a lot of headwinds, and I think Daniel has shared on that. We have shared with you some of our challenges that we have in the payer market, and we think that things are settling. It's moving in the right direction. However, as we alluded to at the end of last year, we think that it's going to take throughout all 2025 to really settle. And we see different payers and different phases of this journey. There are some payers that have started earlier. They proactively done things, taken a difficult decision so that now they're in a better place. We see some payers just starting to do this. A lot of payers are moving from corporate to insurance to managed care even to BPJS. So there's a lot of volatility, but which has affected our Q1, as Daniel has explained. But bottom line is we really do need to grow our volume. So, and therefore, this earnings call, we have shared our commercial initiatives. Now, we have a lot of commercial initiatives. Not all of them we're willing to share here, but we have given you 2 examples, and I hope that will give you confidence on the level of execution that we're doing for each of those initiatives. And maybe if this is an area of interest for everybody, next earnings call will also share with some other initiatives that we're doing to grow our top line. Now, number 2 is on the archetype levers, which individually different levers will contribute to the bottom line. So I'm going to take, for example, community generalists, right? And maybe that's one that's kind of overlooked sometimes, but I think that has a lot of potential, even with some of the changes with BPJS. So it is a cost efficiency scale model. So we have gone into community generalists and looking at how we can go through efficiency in some of the hospitals. It has brought some low-hanging fruit. We are bringing some of those hospitals from like a 0.5% EBITDA to hopefully a 16% EBITDA at the end of the year. And how are we doing this? We are growing the scale. We are downsizing some of the space that they're using. They don't need to operate that much space. So it is very operational and very detailed. The one thing that we do, I know there was a question about this and in the chat, what about quality outcomes? And we've continued to remind everybody that we don't differentiate quality outcomes. We don't differentiate on quality SOPs. All the hospitals are held to the same quality indicators. Clinical quality indicators. Now, of course, on service level, they will be differentiated. On facilities, not facility safety, but on facilities, they'll be differentiated. But we do not differentiate for clinical quality. And so hopefully in the coming months, we'll also be able to share with you the clinical outcomes and how we benchmark internationally as well. So hopefully this answers a lot of the questions, because I see here there are a lot of questions around top line and bottom line, which is fair. And we will continue to update you on progress on the clinical initiatives that we have, as well as the rollout of the architect as well. Thank you.
There is a question on what is the volume of COB patients so far, and since Bukarel was already talking about community generalist. So I'll tell you how COB works. So COB essentially works by you find corporates and insurers and you sign contracts with them. So while I can't state the exact number, but what I can give an indication that in terms of in the last quarter, where we have really started the COB project, we are in the process of signing many such COB contracts, and we are in mid double digits of number of contracts. And now we are seeing the patient flows coming in. So it's a two-step process. First, you do a contract. So like I said, it's mid double digit amount of number of contracts. And then we hopefully we'll see more COB patient inflows as we go along.
Okay, let me take over the question on Scope 3 emission. The question is, how does Siloam plan to address Scope 3 emission, which is typically more difficult to manage? I think that's a very fair and valid question. As we said, we are committing to ESG. For those who don't really understand what Scope 3 means, it's for the other indirect emission. Basically, what we do in Siloam, we're starting to, like we said, we incorporate whatever we do in ESG into our business practice. These are emissions that occur in the value chain, both upstream and downstream, including those from suppliers, business travel, employee commuting, waste disposal, and even the production of medical supplies. So to a degree that we do in our purchasing, for example, for the third party, we do request them to follow and comply to the regulation. So our target for Scope 3 reduction is actually 23% of absolute emission reduction by 2033. So we're starting to put all the framework in whatever we do consciously, so that our sourcing department, our partners, everybody else is agreeing and complying to the standard that we apply. And if they're not, we are becoming very strict into onboarding them into our system. So this is a way of ensuring we truly are committed to implementing ESG in our daily practice.
I'll take a few of the questions here related to
Questions around first read still, like how, when, and everything. So maybe you get to all those questions, and maybe yeah, just recap. I think it was touched on, but there's still a lot of questions.
Yeah, all right, Carol. So let me address that. In regard to first read, well, a primary reason of why we are doing a limited review, obviously, is to support the first read purchase in order to provide the fairness opinion that is relevant. Now, as all of you also understand, I mean, the validity of the limited review, there's obviously a certain limited validity period, which do means that we do we are working with First Street consciously in making sure that the transactions, can be executed this year. So at the moment, we still, I cannot give a definitive date at this stage. A lot of it really depends on First Street getting the unit holders approval and the necessary regulatory approval. But we are still so far optimistic that it will be executed in the 2025. A few questions on the GP margins. I just want to remind the investors that keep in mind that the GP margins, when it's calculated, is not entirely variable cost. There's a part of indirect cost in regard to the nurse's salary that's included in the GP margin calculations. So as a result of your lower productive days in Q1, salary adjustments and so forth, you would then see the GP margins being affected in Q1. So it is a reflection of what I've shared earlier in regard to the lower productive days and disease seasonality. I think with that, we've addressed all
There's
the
a question on pipeline. We didn't share pipeline this earnings call because we shared last month, but just to recap, we have upcoming Surabaya Cito, which is the one that is closest to opening. Then we have Surabaya Manyar, Samarinda, and we have 2 Bali hospitals coming up.
Not to mention that the Gubeng,
Semarang,
Surabaya Gubeng expansion is also happening, and that's also very important.
That's right.
The details of the expansions is still in the appendix of the investors deck, but we just haven't gone through it again this time because it's very much the similar information we shared last month.
Yeah, and also some questions around volume and traffic. I think that has been addressed with the seasonality. So what seasonality does is that it brings more volume, but at a lower RPOB, and also sometimes longer lengths of stay, but lower RPOB. And so in Q1 and Q2 last year, we had unusual seasonality, and Daniel showed what our dengue testing shows us. So this year's a little bit of a normalization. And that is with healthcare business, it's just like that. There is some amount of seasonality that cannot be predicted. And so when there is seasonality, of course, we're there to serve our patients. If seasonality is not there, we try as much as we can to fill our beds with elective procedures. And at the end of the day, we shouldn't be growing from seasonality. I think this is also a trend with other hospitals groups who have also released their results, and they're saying that there is a lower seasonality. So it is something across Indonesia that we are seeing lower footfall because of the seasonality.
Should we conclude the call book, Pak?
I think we've gotten to all the questions generally and all the topics. I guess if nobody has any more burning questions, I think we can end it.
Okay, sure. Okay, thank you everyone for participating in today's earnings call webinar, and we'll see you on the next earnings call webinar. Bye. Thank you, Pak. Thank you, Bu.
Thank you so much, everybody. Have a good day.
Have a good day.